Welcome back, Health Impact audience, for day 3 of Health Impact Spring session. But hopefully this will be one of our last sessions where we will only do virtual. Maybe we'll open up in the next few months for in-person if the rest of the economy allows. Or maybe we'll have a few more as we go forward. But you know, these session styles have been really helpful for a lot of different audience members, and we get a lot of good feedback. Having some great panelists such as Stephanie coming back. I don't know, it's like your 4th or 5th time now, Stephanie. So welcome back. Nasser is coming to visit with us for the first time from Jefferson Health. So today we're going to start the day off kind of like recapping a little bit of what we've discussed over the last couple of days, which is around the strategy for hybrid healthcare, implementation for hybrid healthcare. And a lot of what we're finding is that if you have the right people in the right places doing the right thing, then hybrid really works out well. However, you could have the best technology in the world, and if the right people are not in the right places at the right times, almost no technology is going to work well. And that's why this is a great way for us to start the 3rd day of Health Impact Spring. And that is, how do we reimagine our clinical and technical workforces for hybrid healthcare, especially when 2 big things are going to happen over the next 6 to 9 to 12 months. And that is, the economy is going to open up. There will be some semblance of normality coming. And then the way that we have been hiring people in the past will get a little bit more stringent, because we're already seeing that hiring and identifying people and getting them onboarded into our healthcare systems is going to be even harder. Not only was it hard before, then it was even harder during the pandemic. Now, for a different reason, things will get more difficult. So that's where we're going to spend most of our time today. So we've got a lot of advancements and things going out in the technology side, but that advancement now coupled with the struggles around hiring are both going to be something that we're going to talk to our panelists about. So with that, I'd love to introduce Stephanie. Stephanie, tell us a little bit about yourself, what you're doing at Monument Healthcare out in South Dakota.
Well, excited to be here again, Shahid. These are always fun. So I appreciate the opportunity to participate today. I am the CIO and CMIO at Monument Health. We are a not-for-profit healthcare system based in Western South Dakota. Probably goes without saying that that comes along with it being a rural provider of community health across most of Western South Dakota, some of Eastern Wyoming, and Northern Nebraska. I am an internal medicine physician by background and spend the majority, if not nearly every moment of my time now taking that educational and practice experience and bringing it into the technology arena.
Perfect. Nasser, of course, we've interviewed and had on the panel so many of your colleagues from Jefferson Health. It's a pleasure to introduce you here. Tell us a little bit about yourself and what you're doing at Jefferson.
It's a pleasure to be here. Thank you. And thank you for inviting me. I'm the Chief Information and Digital Officer for Jefferson Health and Thomas Jefferson University. We are a 14-hospital system serving a greater Philadelphia area and a 2-campus university. I have been with Jefferson for about 4 years. Prior to coming to Jefferson, I was at New York Presbyterian, and before that at Yale New England Health. So my career has all been in academic medical centers. So I'm looking forward to that conversation with Stephanie from a community health system and serving largely a rural user base, and us being in a large metro area and being an academic medical center. This should be good.
Absolutely. So let's start off with maybe the simplest question, which is, how does your workforce look different today than it did last March when the pandemic started? Just give us maybe a little bit of commentary there. We'll start off, Nasser, with you, and then we'll have Stephanie jump in and tell us how do things look different from last year.
Absolutely. So look, Jefferson was never known to be a remote work organization. Prior to COVID, we were not. There were a few exceptions here and there, but for the most part, everyone showed up to work, including our clinical colleagues and our corporate colleagues. So COVID did not change a whole lot for our clinical colleagues, but corporate services, so HR, marketing, IT, finance, and university side went online within a matter of a week, but then during last March. most corporate services are still remote. We're working remotely. I'm working remotely from home. And it has worked well for us. And I'll give you an example, a quote from our CFO, who was a skeptic of remote work prior to COVID, and who I think is a convert now, because our productivity has not gone down. And as a matter of fact, in certain areas, we have seen improved productivity. And it has been an evolution. We have onboarded several members of the team who I've never met. So we joke that we don't know whether this is a real person or we're talking to an AI bot. Interaction of the teams. We are conferences. I've not attended a conference in person in over 14 months. We've been doing a lot of panel entries and so forth, and training sessions. One of the key things, you think about how our workflows have changed. We implemented Epic. We went live in over 5 hospitals with Epic just 2 months ago. And entire training was online, virtual training, which was just unheard of prior to COVID, including some asynchronous learning, meaning recorded learning as a CBD model, not live trainer-based learning. And I can tell you that for the most part, that worked really well, to the extent that we are now planning to incorporate that in ongoing training, even when we are whatever the post-COVID work looks like. So certainly in corporate areas, and I know that we're going to talk about telehealth in later part of this conversation, but some significant changes, how workforce look like and how it will look like going forward.
Yeah, and as you were going through that, Nasser, with your colleagues on the training and everything especially on the Epic side, I mean, one of the reasons why it's almost unheard of is because the vendors such as Epic and others want in person, they want these interactions to occur live. How much impact did you see on their side, on the vendor side? And you can talk to obviously just about Epic for now, but were they accommodating? Did they switch as fast as you guys? Were they going faster than you in that switch? How did that look?
So I'll tell you, a very good experience with Epic. But it's, as you know, that an EMR is much more than just core EMR. It's a whole host of systems, right? And it was not, I think, the same for every vendor. Some vendors struggled with remote support. How they would provide, with still travel restrictions in place. We had some vendors who basically were needed on site because of, equipment integration, for example, in areas such as lab, who couldn't travel because of the restrictions. And that was a bit of a struggle, I must say. At the elbow support was a bit of a struggle for us because a significant number of folks just didn't show up. So, we found that some of the things that ADE support has done remarkably well in the past did not really work in a virtual environment. We offered, for instance, virtual ADE, and our user base struggled with it. Okay. In theory, it sounded that it'll work, but in practice, it was not as successful. So I think the short answer is overall, it was a success story. I think if we were to do it again, we would tweak certain things. There are certain vendors that we'll have to relook at certain processes, but overall, it worked very well.
And could we imagine then, and then we'll bring in Stephanie on the Monument Health side, but would you imagine that going forward in your RFPs for selections that you make from vendors or tools providers, et cetera, that you would add some of these learnings and say, hey, going forward, we don't want any pure in-person. It must be a mix or mostly remote. Are you ready to kind of like put that into future RFPs, or is it too early to do that?
It's too early to do that. I would say what we are very open to now, the big change is that we are open to hybrid. Okay, so if someone were to come to us and say, hey, look, this training, we can do hybrid. As a matter of fact, for our thought on ongoing Epic training is exactly that. That it used to be in-person training for new hires, right? We are virtual right now. And even when we return back, actually, there are economies of scale for us to keep some parts virtual, because with 14 hospitals, it's impossible for us to be at 14 places, right? Mm-hmm. And it's very difficult, especially some of the hospitals that are distant and some of the physician office, to drive for a 3-day training every day, Okay, so we expect that to be in hybrid. So I think a hybrid mode, we are a lot more open now than we were, before COVID. And with some exceptions, I think probably we are not at a place where we are going to just claim up it's all remote at this point for all Jefferson now. I don't think we are there.
Got it. All right, great. So Stephanie, how does your workforce look different from a year ago?
I think we have a lot of similarities. My team was kind of 2/3 from home prior to this, which was great because we had some learnings and some experience and kind of when we had that same 1 week to get everyone else home. And again, that's more on the corporate side. Just to highlight a few different elements that I think about when I think about sort of the change of our workforce, what they're doing, and maybe some to an extent of how they think. First, one of the things that we've seen over the last year is, as a health system, we're doing a better job of acting and behaving like a health system. And because, at times there were so many, the demand for service and information to be delivered and those kinds of things was so great compared to the resources we had to be really, really efficient in how we did that. And so that we had a lot more coordination between our small hospitals and our big hospitals, between some of our clinics and urgent cares and things like that, because again, everyone had more on their plate than they really were used to having. So it caused us to come together in times where it had been easier before to kind of say, well, we like having our own little carved out part. And so now we're really leveraging a lot of that system thinking, and it has allowed people, particularly, I think on the operations side, to sort of let go of some of the ownership piece that they used to have over certain workflows and certain roles in the organization, because really the name of the game at this point is efficiency. And it's efficiency for multiple reasons. One, despite everything that's happened over the last year, and fortunately, lots of our organizations received federal funding and things that kind of helped keep us afloat while these things were dynamically changing. But the reality is, as we go back to whatever normal may be, we're coming back to the discussion of, the efficiencies that are needed, because the crunch on how much we spend to deliver care is right back at our forefront, and we've got to be super efficient. And then the workforce challenges. I mean, I think we're seeing in our area, our unemployment rates are at an extremely low level, and we're seeing, the other thing that's interesting is the shift in competition for some of these great resources. Now that so many of us have work from home strategies and even potentially opportunities for people to live in another region, we're competing with organizations and or industries where we weren't before, because you had to physically move. If I wanted to work for Jefferson, I had to move. Now they might be willing to hire me living in South Dakota, and vice versa. So we're also seeing, I think, some of the elements of how do we really make our workforce as efficient as possible, and then finally, as happy as possible. That's another real emphasis that I've seen coming out of COVID, partly because I think, we saw our workforce all work extremely, extremely hard to provide for our communities, do the right thing, and get us through that. And we have a new level of appreciation across whether we're talking about our clinical or our corporate partners, everyone banded together to really to drive home outcomes. And now we're saying, gosh, we really appreciate that, and we need and want you to stay. And so I think there's also an interesting shift happening in healthcare right now around workforce and what do we need to do to be that place people want to work? What do we need to do to accommodate their lifestyle needs, their schedules, their whatever, because for a long time, like many other areas in healthcare, we always sort of said, well, we're different, we're healthcare, we're 24/7, we're 365, you just got to live with it. Kind of like we did with technology. Well, we're on these kinds of schedules. We only do, we do capital and these kinds of, don't talk to us about these things out of this sequence. And all of that has been uprooted, right? And we're sort of saying, gosh, we have to think differently. And so one of the things I think right now, as I look at workforce in general, is just an overarching across the organization willingness and emphasis on thinking about workforce differently in all areas.
No, I love that. In fact, that's actually pretty astute when you're thinking about, especially the competition angle, and maybe extending this question on what's changed is coming up now over the next 6, 9, 12 months, because unemployment rates are going to change. And whether it's McDonald's or Amazon or Monument Health or Jefferson, everyone's going to have trouble maintaining workforce, attracting new people, keeping them happy, et cetera. So Stephanie, do you have any quick comments about what you're doing to maybe keep the people that you definitely have now, saying that, hey, don't start looking around post-COVID, stay with us because we love you and we're going to take care of you, et cetera. And then in addition to that, what might you be doing to maybe attract people from, Philadelphia or California to say, hey, fine, stay where you are. We just want really, really good workers. So Stephanie, any quick advice there?
Yeah.
And then I'll jump in with Nasser as well.
Yeah, I mean, I think first of all, we can all be looking and should all be looking at automation opportunities, right? If we can automate the sort of easier tasks, one, we may need fewer people to complete all of the tasks that are necessary. And it allows those people that are remaining to do tasks that really leverage their skill set, their licensing, whatever it may be within their area, so that they're hopefully getting the most enjoyment and fulfillment out of the work that they're doing, because they're working at the highest level of whatever their training or licensing would offer. So I think when we look strictly at non-HR related, benefits and retention and those kinds of pieces, but really the work itself, it's identifying how to get all of our team members to be able to work at that highest level. And then also shifting, as we shift some of that work into automation, maybe that changes a bit the construct of who and how many people we need, which then potentially allows us to employ fewer people, but we pay them better, or we do offer them better benefits, right? It's kind of a circular element of you can do more on certain sides if you can shift in others. So I think automation and some of that is really a main focus for us. And that is on the clinical side as well as the corporate side.
No, I totally agree with you, Stephanie, that's a good virtuous cycle for us to start the flywheel on. And maybe to look at it, there's might be two angles to look at that automation. For some of you who may remember, a few months ago, our keynote at the HealthIMPACT winter was stop doing stupid stuff. Basically, there are a lot of things that hospitals and health systems have, built cruft around for decades, doing silly things, even though we've got good automation capabilities. We either don't spend the time on it or we have other priorities. And so kind of like, nurses and doctors and admin people are just doing silly and stupid things over and over again because nobody actually spent time looking at it. I think this idea of automation has two angles. One is basically telling people, hey, we've stopped doing stupid stuff. We're automating. That's why you're going to find a better place for you to work here, right? Or the alternative, which is if you start the flywheel, that virtuous cycle going, you don't need as many people, but I get the feeling that it's the former that may make the most sense to get and attract more people. Nasser, talk to us a little bit about, just basically commenting on what Stephanie said about advice for how do you start to at least retain and then start to attract in this new world order. And then this idea of spinning that virtuous cycle going, how could you implement better techniques to keep people without doing more and more silly things that we've been doing in the past?
So I think Stephanie said it very nicely that, look, I think automation is a pretty significant part of our risk strategy. And as you said, like the things that can be automated should be automated. I'll just start by saying that, people, we serve Philadelphia metro area. So there are many other very reputable employers where technology teams can go out. A network engineer is a network engineer is a network engineer. They don't have to work in a health system. The people who work at Jefferson because they have a sense of mission. All right, so they want to work for a not-for-profit organization. They want to make a difference. During COVID, like many other health systems, Jefferson went through a tough time financial pressures, et cetera. And we saw several health systems were forced to do things like layoffs or, Jefferson decided that we are going to keep our employees whole. We did not do any layoff. It was a tough decision, but we really kept our people first. And that was very intentional. We early on decided that we are going to do everything possible for employees, and our employees take notice of these things, when, especially if you look at the surrounding, and with nobody's fault, the people were, other health systems were laying. So there is a bit of a trust that Jefferson has with employees, but I think these things only go so far. So we are focusing on things like cloud, for example, right? In addition to automation, where we have been in this data center business for decades now, and this is not a core competency anymore. I mean, Amazons of the world, Microsofts of the world do this so much better, right? And we have been slow at Jefferson in moving to cloud. That is, in next 3 to 5 years, we are going to be moving to the cloud in a pretty significant way. I expect probably 80% of our assets to be in the cloud, which frees up our manpower within IT to focus on more application, more impact, rather than the back end kind of things that we have been focusing on. I believe that partnerships is going to be big going forward. You think about area of cybersecurity, there's no way we can retain and hire, let's say, a security operations center. All right, it's not going to happen. We just don't have that kind of, the talent is not, even if we wanted to hire, this talent is not available out there. It means that we have to partner with other organizations. And I use the term partner very carefully, because we have tons of vendor-vendee relationship, right? But I think what we're looking for is a lot deeper relationship where we would trust someone in caring for Jefferson as they care for their own organization. And that's what I mean by partnerships. I think that is going to be very important, at least in next few years. Our employees like flex work. Our employees like hybrid work. We are thinking hybrid. We are still not at a point where we believe that we are going to be 100% remote all the time for foreseeable future, but our employees are bought into hybrid work, flex time. We support careers, investment in training, promotions, internal promotions, retention. We are incredibly proud of our tenured employees. So these are some of the things strategically that we are doing to make sure that we are balancing our work and prioritizing what should be our core competencies, and also retaining our workforce.
Yeah, I love it. So that point that you made about mission, I think you hit the nail on the head, because sometimes people just want to work somewhere important. Like at the end of the day, they want to make sure that things matter to them. And as we think about that one piece, which is mission, we start to recognize that not everything can be handled hybrid, right? You can't do a surgery completely remote, but there are other areas such as nursing, surgeries, mental health, that are also going through paradigm shifts. So I'd love, Stephanie, what are you seeing from your vantage point as CIO? Are other groups coming to you to ask you for digital tooling or digital capabilities or information capabilities beyond the traditional hybrid healthcare, like the telehealth of the world? And if so, talk to us about what are some of the learnings in the last year around things like, I think mental health probably is the one you could pop up really high, but what about just nursing, home care, surgeries, like the ones that literally have to happen inside hospitals? Tell us a little bit about what's happening beyond pure telehealth in the hybrid world.
Yeah, well, I mean, I think there are some things that are happening right now, and then there are some things that we're on the precipice of seeing with AI and machine learning and some of these pieces that are going to really take off. So things that are happening right now, my surgeons, clearly need to operate in the hospital. However, some of their follow-up appointments and things like that, we've done telemedicine. That's sort of already traditional kind of things that we're thinking about. Some patients, that's still not going to work, right? Either they don't have the ability to do that or something's going on, they still have to come in. So there's still the question of, how do I make that surgeon more efficient? Well, I can offer him tools that complete the documentation for him, right? So automated documentation tools, integrations within the EHR that allow for less face time with the computer screen and more face time with the patients might give a physician an opportunity to see 3 more patients in a day. If that one person can see 3 more patients in a day and we have 500 doctors, now we've got 1,500 visits that can happen in a day. So I think we're looking at tools that can help all of our physicians be more efficient in the work that they've always had to do, particularly in the inefficiencies around working with the EHR, and see if we can give them some of that time back. Similar with clinical decision support tools as well, given that the amount of information to assimilate and keep track of is becoming hugely robust and more than any one mind can take on. When it comes to nursing, we on the inpatient side, we're doing team-based care and looking at some different models for how to deliver care. But on the outpatient side, and as we look at ways to be able to potentially work more in people's homes, again, we're coming back to that centralized model of looking at, centralized nurse triage or centralized resources, maybe even a centralized virtual urgent care or something where now you've got one group of people focused on doing that work and doing it really well. Typically speaking, that means that then they'll be able to see more people, they'll be more effective and more consistent with what it is we're trying to accomplish. Getting the right patient to the right spot where they need care at any given moment and navigating patients through that helps everyone be more efficient. And then as I look a little further out, when I think about, for example, mental health, the reality is some of what's coming with AI, machine learning, voice analysis, some of these kinds of things is we're going to be able to, kind of like in radiology where we're seeing already, like it's not going to diagnose the cancer, but it can certainly say, gosh, I did a voice analysis on this person and we should definitely see them first. Or, we did just like, I looked at the CT scan and this one looks more concerning versus this one. And then over time, potentially being able to leverage some of those tools to, again, allow the psychologist, psychiatrist, whatever, to do the highest maximal element that really requires their thought process, their critical thinking, their knowledge background, but serve up a lot of the other information to them in a more effective and efficient way. It's going to take a little time to get there. Our clinicians obviously need to understand what's in the black box that is being presented to them to trust it and want to rely on that information. And our patients are going to need some time as well. And so I think this is where some of the baseline digital tools that we're using with them now, engaging them in whether it's online questionnaires and looking at results, and then potentially utilizing ambient voice in the room to be documenting. Patients are getting more comfortable with technology sitting in the intimacy of that relationship because they have to come along with us. We can't throw all these tools out there and say, hey, we'll reduce the need for psychiatrists in half by doing voice analysis and whatever, when the patients are going to say, well, I'm not talking to you. If you're analyzing my voice, I don't know what else you're doing. I already don't feel super comfortable. So I think there's a lot of great stuff happening there. And it's trying to set our sights on what can I do right now, and then what's coming.
Got it. We've got about 5 minutes before we're going to open it up for our Q&A session with the audience, and some questions have already come in. But what I wanted to do, Stephanie, is it fair to say that primary care and behavioral health may increase more on the telehealth and remote and other side. But when you look at things like radiology, surgery, the things that are happening in-house, more and more efficiency and automation through things like ambient listening, automated documentation, claims capture, et cetera, Is that fair to kind of separate it that way so that vendors and technologists and others can look at it in those terms about how much more you want to do in telehealth on one side versus the other?
Yeah, I mean, intellectual specialties, obviously every specialty in medicine is intellectual, but those specialties that basically are singularly dependent on, you know, more me articulating and bringing information together and those, and less on the procedural and exam side, is definitely where we're going to see those pieces go. And so, you know, if you're looking at proceduralists, yes, how do we make them more efficient? If we're looking at primary care and some of the other highly intellectual specialties where it's mostly around consuming information and critical decision making, I think there's the opportunity then to make those things virtual.
Great. Yeah. So Nasser, we'll let you kind of like summarize this and take us into the Q&A piece. But how are you looking to staff and train and reskill the workforce for these kinds of things that that we're discussing here, which is things are going to shift more and more in certain areas, more and more remote. Those have not been taught to people, as we learned over last year in medical school, et cetera. But you still got to do it. And the reason why I was posing this question to you is you're an AMC. Obviously, you're training the next generation. What does that training look like that is different going forward over the next 3 to 5 years than it was in the last 3 to 5 years based on everything going on?
That's a great question, and you're right. You know, so first of all, I would say that change is already happened, right? Just COVID really truly accelerated the change, right? I can think of several skeptics of telehealth that are now believers, right? Our belief is that telemedicine is medicine, right? We have a senior executive focused on telehealth. We have created a curriculum, especially around digital care, which the younger generation is already being trained on. I think, you know, we have to think about this in a different stakeholder perspective, right? So the interesting thing is that we are seeing demand from our patients, right? So that's consumer is really demanding for digital health. And that's how this is all started, right? And I think independent providers, hospital systems, we are pivoting somewhat reactionary to COVID and then patient demands in terms of, you know, with the barrage of the wearable devices, et cetera. How do we consume that? How do we react to that? And there is, you know, an art to that. You know, there is a bit of an information overload that's happening because not every bit of, you know, information from an Apple Watch or et cetera is going to be meaningful for a provider. So training, I think, and taking into account the patient as a whole is a process that is happening. I think it will continue to happen. We have a specialized training around it. And I think we will probably pivot many times before we come to some set of steady state. And I think that steady state probably is a few years from now.
Mm-hmm. Yeah, and so when you think about what's coming in a few years from now, obviously the next group of students are already coming in. You know, one of my cousins just graduated with her MD, and her entire last year and a half was purely virtual, right? So you know, obviously she's going to go through a lot more differences in the way that they're going to interact with the AMCs than others. So what are a couple of things that you would tell the med students of tomorrow to say be prepared for, which might look a little bit different than what you would have told to people, say 5 years ago before all of this happened?
A lot more interaction from patient, a lot more inquiries, a lot more educated patients, right? So you know, these days already with Google, et cetera, you have to be prepared for all sorts of questions. A lot more, I think, you know, reliance on artificial intelligence and predictive modeling. I think that just, you know, I believe that AI will never replace a provider. It will augment provider. And that's just going to be a different kind of environment where I think our students have to just be prepared. Things like virtual reality, I think they'll be just part of some of the you know, care that we provide. It's already is bringing. Right now it's more on the educational side of things, but going forward, clearly, I mean, these things are going to become part of what is being provided in working with, you know, these independent startups, cutting edge technologies. that are working. You gave an example of behavioral health. There are organizations that are working that are not healthcare organizations. These are just technology startups that are trying to improve health and doing a fairly decent job. Behavioral health, we are working with a startup that are also things like journaling and patient notes, etc. Look at EMR, look at what patients are providing, and then alerts based on their AI model to the provider. And these are the things that, prior model, I think, was a lot more dependent on physician expertise. It will still be dependent on physician expertise, but it'll be augmented by some really cutting edge technology of the future.
Yeah, that's great advice. So with that, we're going to close up our primary session here, open it up for Q&A. You've got the great panelists, two great experts in this area. Please ask away, ask questions like, how do you support burnout and other questions. We've covered burnout a lot at HealthIMPACT, so I didn't ask you that many questions about that, but it's possible that some of our audience may jump into that. So with that, I want to thank Stephanie. I want to thank Nasser. Please ask away your questions now. All right, so we've already had a very, very active chat going on, and I know that a lot of you got your questions answered there, but as soon as our panelists join here, we will then, anyone who wants to come on live, please do raise your hand in the little chat button, and then we'll get you on live. Otherwise, what I'd like to do is maybe start off. So Stephanie, you made the announcement earlier that you had your first remote hire. We'd just love to hear about that very quickly. And then I'd like to ask both of you, Stephanie and Nasser, about this outsourcing question that just popped up as the last piece, because that has a direct impact on workforce. So Stephanie, tell us about your first remote hire and how's that going?
Yeah, it actually relates to the comment or question around outsourcing. We've been doing some managed services pretty successfully in a few areas, and I'm gonna turn my volume down. I feel like, is that better?
Yep.
So we've been doing some managed services in a few areas, and while we were super happy with the way that worked out from the standpoint of what we were getting, the product that we were getting, we're paying about 3 times, what we would be paying for an employed person, 2.5 to 3 times, depending on what role we're talking about. And so, but part of the reason we were doing that was in my local area, so I couldn't find the resources with the level of experience. And so, and until literally the last couple of days, employing somebody who lived outside of the state of South Dakota was not something my organization allowed. It just was, we had a rule, nope, you have to live in South Dakota. And so, that's one of the, I guess, silver linings for the pandemic, and me being able to talk with our legal and HR teams about the elements that go into what it takes to be able to manage some of that. But I said, I have a real operational need in order to meet the demands of the organization to potentially, employ people who live in another state because they can adequately do that work. And so we were able to work through those details, and excitedly, bringing somebody on board who will be working with us remotely. And so now the real question will be, how do we, onboard that person to the team, right? How do we maintain them as part of the team and feeling included and all of those kinds of things, and kind of move on from there. But it's a good problem to have, and I'm excited to see that we've been able to move in that direction.
Yeah, that's great. And so Nasser, do you want to comment on that cost? 3 times seems like it's outlandish, but maybe from a fully burdened perspective. But Stephanie, were you saying from a fully burdened cost perspective, it was 3 times more, or just salary wise or something like that?
Yeah, so the contract for, sort of a full-time, long-term resource outsourced through maybe it was a combination of it was not true total managed services, more like long-term consultation with a dedicated resource who, again, highly, highly efficient, really at the very, we would hire them as one of our highest level analysts. But in order to do that, they were probably 1.5 times as productive, but still that's a lot different versus me employing somebody. So we're trying to figure out the blend of that. I can afford to do a little bit of that because we get some really great work out of those people, and they have a lot of background and knowledge, and that's part of what we're paying for. But I can't outsource my whole team in that way.
Yeah, makes sense. So there have been other related questions around outsourcing. Nasser, you can pick up that one, or you were responding to a couple of other questions on there. Which one would you like to hit? The outsourcing one first?
Actually, I just want to comment on the partnering versus outsourcing. So I think someone commented that, partnering is like outsourcing, and I think I'd like to just differentiate a little bit. So we do have outsourced relationship where, and I think the nature of those relationships, at least in our mind, is different, where we talk about services and SLAs, and we hold people accountable for what we contract on them to do. And SaaS is perhaps one of them. IaaS is one of them, where someone is hosting a service. We are just asking them uptime, etc., how they get things done. Details, I think, are generally shielded from us. And we have several of those, and those are more outsourced. Like partnering, I think, in our mind, is a little bit different, where we consider folks essentially an extension to our team. And there is an expectation, goal settings, the incentives are aligned that way, where it's more outcomes based, and we both share the benefits or the downside. So I think there is some difference, at least the way we are thinking about how we work with some of the partners. And there's no question, look, some of this is going to be pure outsourcing, and there are services, perhaps training, perhaps some of the help desk, etc., traditional, some new areas, which are, I think, going to be ripe for outsourcing, given the more acceptance of remote work. So I just wanted to make that distinction.
Yeah, that's a good distinction. In fact, the way to think about it really is in 3 building blocks. One is staff augmentation, where literally they're a part of your team, and you kind of like hand them things to do, and you do full management of that team as if they were your own. Then there are these project-oriented human beings, where you give them a project. You still know exactly who they are. Like, it's Shahid, and I'm doing the work, but you don't manage me, you manage the work, as opposed to in staff aug, you manage that. But then this third one, I think, where we need to start thinking about is, how do I just hand out the work and not care about it on a project management basis and the deliverables basis only, right? Because here's the struggle is, if you're paying 2 or 3 times more for staff aug, that's actually a lot worse, because you still have all the management burden. Right, that's really what's caught my ear, Stephanie, is that if you have staff aug 3 times more, project base 3 times more, might be worth it, because you've saved some cost on the management side. But it's really important to distinguish with these separations more properly. With that, Chris had a question here. How would you like to see tech help you more with your workforce of the future vision? We've got about 3 minutes, so 90 seconds each. Stephanie, we'll let you go first about that question from Chris.
I think in a word, I would say automation, right? Help me take the easy stuff and make it easy, or not even there.
Got it. Nasser?
Very similar to Stephanie, like things like automation, things like cloud, where we are just taking work that our team used to do, managing servers, tasks that can be automated. And not necessarily value add, right? So the tasks that are not necessarily value add, how can we use technology to just either offshoot via automation, or just have someone else who can do the work better than us just do it, and that allows, I think, our team members to I think work better.
Yeah, and I think that so both Stephanie and Nasser are a lot nicer than I am, so I'll be more poignant here. Number one, don't bring tech to a Stephanie or a Nasser and then add to their management burden, right? The thing that you want to offer the tech is, don't make my job as a team leader, as a manager, et cetera, more than it was before you brought in your tech. That's number one. Number two, if you're going to provide the tech, make it highly supportable, fully remotely, without adding additional management burden on the support side. So there is this, operational frontline requirement where tech now needs more people to operate the tech than it did to even do the work before the tech. So it sounds like a silly thing, but we've now done that over the last 10 years, primarily because of compliance to meaningful use and other things. But I think if you just keep an eye on those two things, because nice people like Stephanie and Nasser may not tell you, like I would, is like, this is bullshit, guys. You're giving me a tech in which I have to do more work. How is that useful to anybody?
Shahid, I think one more thing, if I could just add on, is I also think it's really important to understand the sort of the context of the digital patient journey, and understand where you're potentially looking to automate. This revenue cycle side, great, super safe, easy, not super patient sided. But if you're going to be on the patient side of things, you need to really understand our patients have to adopt this, right? I mean, if you don't interact with technology at all and your first automation is we remove the check-in person and a robot drives up to you in the emergency room to check you in, you're gonna be like, I don't, what is this, right? So understand what that journey is and how deeply in that environment you are trying to insert automation, and determine whether culturally and everything else, like our patients and our caregivers ready for that portion to be automated yet. No question we'll get there eventually, but I think there is a natural process to that, because otherwise some of these things are going to fall flat, not because they're the wrong tool, because people aren't ready to adopt them yet.
Yeah, great point. So we're unfortunately run out of time. We could get this conversation continuing really well, but we have a next session starting right now. So Stephanie, thank you for joining us right before your summer vacation. And Nasser, thanks for joining us, and we'll have you at a future Health Impact as well. Thanks everybody in the audience. Please join us in 45 seconds. Bye all.